Good morning and welcome to the Global DAT Task Force hosted Learning Hub. This is the second webinar that we're hosting under the Learning Hub with the topic Ensuring Sustainability of Digital Adherence Technologies. So the objective of the Learning Hub is really to stimulate peer-to-peer learning. And so please feel free to engage, post any questions that you have in the chat, and we'll come to those throughout the webinar. So as an outline of the session today, I'll be kicking us off. Sorry, just give me a sec. My laptop is making sounds. Just give me a second. So as an outline today, I'll be providing an introduction of sustainability within the digital adherence technology intervention, as well as some considerations for sustainability. Then I will be handing over to Tawfik Abdurrahman from Ethiopia, and he'll be presenting on their experience under the Ascent project. And then lastly, I'll be handing over to David Asimwe with his experience within Uganda of implementing digital adherence technologies. So in terms of intervention sustainability, you can look at it from two angles, basically. The first being the sustainability during the actual implementation period, and the second being the sustainability that is more long-term within programmatic strategic planning. So largely today we will be focusing on sustainability during implementation period, and there will be a few components related to more of the long-term sustainability, but we're not going to dive too much into that for now. And in the future, should there be interest, we'll host another session in the Learning Hub related to long-term sustainability within programmatic strategic planning. So in terms of the sustainability during implementation period, some of the aspects to consider is to make sure that it's continued and successful rollout with limited interruptions. And this is related to the day-to-day functions and procedures within a country to ensure that the implementation is sustained. And then the last aspect to keep in mind is that it needs to be an iterative process throughout implementation so that you can adapt the intervention over time to make sure that you're meeting the needs of the target group as well as the implementation context. Then in terms of the long-term sustainability, this is more focused at the funding side, as well as transitioning from project-based to global funding to local funding. It's also looking at scaling up from a pilot implementation to more a scaled-up implementation within the National TB program. Then it also looks at ways in which you can integrate your intervention into existing and local interventions. So if you consider digital adherence technologies, this could form a part of the greater adherence strategy. So you could look at how DAT support adherence on the whole and isn't just a standalone intervention. And then lastly, you would consider within this how you might utilize the data that's generated from digital adherence technologies and feed that into future strategic planning as a country. In terms of considerations for sustainability during implementation period, this is just these are just a handful of considerations, although my colleague Tawfik and David, colleagues Tawfik and David will be providing more insight. So in terms of in terms of considerations for sustainability, you need to make sure that the technology you're selecting is suitable for the target group. In addition to that, you need to make sure that this technology is available continuously both for the person with TB who is using the technology to support them with adherence, as well as the healthcare provider on the other end who is tailoring support based on a person with TB's adherence pattern. Then the third component to consider is establishing feedback processes. So this is not just during the intervention in terms of monitoring and evaluation, but also looking at feedback processes at the design of the intervention within your context so that you know that the intervention is meeting the needs of the target group. You would also consider feedback processes for improvement of the intervention, and you could leverage the adherence data that's generated from DATs to refine the implementation. Then the fourth component is an enabler for the consistent implementation, and the first is integrating it into the health system, and the second is integrating it into the healthcare workers' workflow so that it's not an additional burden for people to implement, but that it streams along their general workflow. Then the fifth component is looking at training and supervision cycles. So this is training at the initiation of digital adherence technologies, just to familiarize people with this new concept. But once they have begun implementing it, also considering refresher trainings so that you can embed that learning. And it may also be with staff rotations, that there are a number of staff at health facilities who are not yet familiar with the technology. And so to also provide refresher trainings for that group of people. And then lastly, you would need to consider supervision visits to facilities. And this is really to have that hands-on, on-the-ground learning experience and really to assess what the implementation is like on the ground, and from there also to feed back into the feedback processes. Are there adaptations that need to be made? And then the last component is ensuring that you have established standard operating procedures. And that is looking at the procurement of whatever technology you're using as a country, as well as the preparations of these technologies. So that's at a central level, as well as healthcare facility level to the person with TB. And then lastly, you would need to look at how you go about distributing these technologies from central down to health facility level. So that's basically an overview of sustainability. But I want to hand over to my colleague, Taufik Abdurrahman, and he will provide on-the-ground experience in Ethiopia. So Taufik has experience under the Ascent project. He's the deputy project manager for Ascent in Ethiopia. And I'm going to hand over directly to Taufik.
Yeah, okay. Thank you, Enes, and welcome everyone. Today, I'm excited to discuss the sustainability of digital adherence technology during the Ascent implementation in Ethiopia. As Enes said, I am Taufik Abdurrahman. I am the deputy project manager for the Ascent Ethiopia project. In my presentation today, I'm going to provide a quick overview of our journey with the Ascent project, focusing on ensuring the long-term sustainability of our digital adherence technology intervention. I will start by exploring the background of Ascent Ethiopia. Following that, I will present the strategies we have implemented to sustain our intervention, outlining our approach toward the sustainability. Next, I will examine the challenges we have encountered in ensuring the long-term viability of our D8 intervention and the solution we have devised as well. Additionally, I will share some inspiring success stories that underscore the impact of our intervention. Finally, I will conclude by reflecting the lesson learned through the implementation of the project. As a background of ASCENT Ethiopia DAT implementation, ASCENT stands for Adherence Support Coalition to NTB. It has been implemented in 5 countries: Ethiopia, South Africa, Tanzania, the Philippines, and Ukraine. In Ethiopia, it began in July 2019 and concluded in December 2023. The primary objective of ASCENT project was to assess whether implementing DAT alongside a differentiated response to treatment adherence, monitored daily through a mobile app and a web-based platform, reduces the number of adult DSTB patients with poor end of treatment outcomes compared to using standard of care alone. So along this, the project has also evaluated the effectiveness, acceptability, feasibility, and cost effectiveness of the intervention. During the project implementation period, we utilized 2 DATs to support patients in adhering to their medication regimen. Medication label and smart pill box were the technologies that we used during our implementation period. The medication label is a technology that enables patients to take a step code to a short number to report whether their medication has been taken. And the smart pill box is a device that records medication intake whenever the patient opens the box. The ASCENT Ethiopia project was implemented in 2 regions, Addis Ababa and Oromia, across 78 facilities. Among those, 52 facilities implemented the DAT, while the remaining 26 facilities served as standard of care facilities for comparison purpose. As of the end of December 2023, we had enrolled over 4,300 patients using the DAT, including both medication label and smart pill boxes. Additionally, more than 1,400 patients were enrolled in the standard of care facilities. In total, more than 5,700 patients participated in the project. If you want to learn more about the implementation of DAT in Ethiopia through the ASCENT project, please review the webpage at digitaladherence.org/Ethiopia. So, what were the strategies that contributed to both the success and the sustainability of DAT intervention in Ethiopia? Government partnership and integration, capacity building and training, user acceptance and engagement, continuous monitoring and evaluation, community engagement and education, as well as technology sustainability, were the strategies we implemented to sustain the DAT intervention in Ethiopia. Now let us examine each strategy individually. The first one is the partnership and integration with the government played a crucial role in successful implementation and sustainability of DAT through the project. The Ethiopian National TB Program, in its strategy, in its national strategic plan for the period of 2021 up to 2026, emphasized the use of digital technology, including feasible digital adherence technologies to support treatment adherence. So this policy greatly supported our effort to sustain the intervention. Additionally, closely working with National TB Program and regional health bureaus played a crucial role in achieving this sustainability. Investing in the capacity building and the training of healthcare providers, it was really the paramount. Throughout comprehensive training programs, we equipped healthcare professionals with the necessary knowledge and skills to effectively utilize DET in their daily practice. These sessions were conducted periodically to ensure continuous skill development and adaptation to evolving healthcare needs. Given the potential turnover in healthcare staff, we ensured that training sessions were regularly scheduled to accommodate new personnel who may not have received training previously. Additionally, we extend our training effort to include supervisors, equipping them with the tools and knowledge needed to support and oversee the successful implementation of DET within their teams. So this approach to training not only empowered frontline healthcare workers, but also it strengthens the overall capacity and resilience of the use of DET to deliver quality care. Another key strategy is the user engagement. We adopt a user-centered design approach to develop the DET platform. We actively involved healthcare providers in a periodic review of both the platform and the mobile application, gathering their feedback to improve usability. So based on their input, we refined and implemented enhancements to the platform and to the mobile application. Additionally, we established feedback mechanism to collect comprehensive user feedback and ensure all concerns were conveyed to the app designers and implementers for the prompt resolution. Implementing robust monitoring and evaluation mechanisms enabled us to track the progress and performance of DET implementation in real time. So regular assessments allowed us to identify areas for improvements and take corrective actions promptly. We continuously monitor key performance indicators. We could ensure the quality and effectiveness of DET services while maintaining the accountability and the transparency. Additionally, the supportive supervision was a key aspect of our approach. This involved activities such as utilizing the standard asset supervision checklist. We conducted reviews of the recording system and data management, including logbooks, formats, and the UniTB register. We also checked DET implementation and we resolved any challenges encountered during the project implementation. This ongoing supportive supervision ensured and facilitated the identification and resolution of issues that could potentially hinder the effectiveness of DET implementation. So the distribution of DET, including both smart pill boxes and medication label, was well planned and managed effectively. by establishing and fostering partnership with the civil service organizations and the community advisory boards, we facilitated dialogue and addressed any misconceptions or concerns surrounding DAT. Through interactive workshops and outreach activities, we empowered community members to take an active role in their healthcare journey, ultimately enhancing the sustainability of DAT implementation at the grassroots level. So these collaborative efforts not only strengthens community engagements, but also ensured that DAT services were tailored to meet the specific needs and perfect of the local population. The picture here shows a few of our CAP members during their visit to one of the healthcare facilities. Of course, technology sustainability should also be considered for the overall DAT intervention sustainability. This includes periodically backing up of the system, proactively monitoring the functionality of the platform, regularly updating the firmware of the smart pillboxes, and addressing any other technology, system, and infrastructure related issues to ensure a smooth operation. So minimizing downtime in case of any issue is crucial for uninterrupted service delivery. So in summary, the combination of these strategies, the government partnership, capacity building, user engagements, monitoring and evaluation, and so on, formed the foundation for the successful and sustainability implementation of DAT in Ethiopia. In the next few slides, I will explore these key areas where sustainability can encounter challenges: financial sustainability, technical challenges, user acceptance, and infrastructure and connectivity issues. So each of these aspects plays a pivotal role in the success and continuity of the DAT intervention. The first one is a financial sustainability, securing adequate financial resources for sustaining the digital adherence technology intervention over the long term can be challenging, especially in resource-contained settings. Regarding the cost effectiveness, balancing the cost associated with implementing and maintaining the DAT intervention with the benefits occurred in terms of improved healthcare outcomes and its reduced healthcare costs. The other is technical challenges. The other one is the technical or technological challenges. Software maintenance, ensuring the continuous functionality of the DAT system through regular updates, bug fixes, and technical supports. It is really very important. The other is the data security, safeguarding patients' data and maintaining compliance with privacy regulations to mitigate the risk of data breaches and unauthorized access. The other is integration, integrating the DAT system with existing healthcare infrastructure and electronic health record system to facilitate seamless data exchange and interoperability. Infrastructure and connectivity issue is also another challenge. For example, limited access, inadequate infrastructure, including internet connectivity and mobile network coverage may hinder the widespread adaptation and usage of the DAT system, particularly in remote areas. Technology literacy, addressing disparities in technological literacy and access to digital devices among the different population group of ensuring equitable access to DAT intervention. The other is power supply, actually, ensuring reliable power supply to support the operation of digital device and prevent the disruption in service delivery due to power outage or shortage. And the other is user acceptance, behavioral change, encountering patients to adopt new technologies and adhere to the prescribed medication regimen by addressing psychological barriers, misconceptions, and resistance to the change. And user experience, it's really crucial to design user-friendly interfaces and intuitive workflows to enhance user acceptance and engage with the DAT system. Continuous engagement, implementing strategies to sustain long-term user engagements, such as personalized feedback, reminders, and incentives, actually. So addressing these challenges requires a comprehensive approach involving collaboration among stakeholders, innovative solutions, and adaptive strategies to tailor the aspect context of the Ethiopian ASCENT DAT implementation. Okay, the success stories. This is one of the healthcare worker in one of our intervention facility. He gave us his testimony that by using this technology, he got a lot of spare time, and then he could support other colleagues since he gets spare time in using of this technology. This individual in the picture is one of our patients who completed his treatment using the smart pillbox. He shared his testimony by expressing that having a smart pillbox is important to having a person, a private doctor at home. This individual is another one of our patient who utilized the medication label technology to manage his medication. He provided his testimony stating that if he hadn't had access to this technology to support his medication regimen, that he would have likely discontinued taking his medication. This is one of the healthcare workers in ASCENT Intervention Health Facility. She shared her testimony about how this technology helped her. She mentioned that thanks to the technology, she now has more time to support other activities in the clinic. So, what was the major key takeaways and lesson learned during the project implementation? I have listed out 4 major key takeaways through through certainly not only once. The first one is Ascent Ethiopia successfully implemented digital adherence technologies, DATs, for tuberculosis treatment, improving treatment outcomes and patient-centered care. The second one is the research findings from the project highlights the acceptability and feasibility of DATs in the Ethiopian context. The third one is the cost-effectiveness analysis of Ascent Ethiopia provides valuable information for policymakers and healthcare stakeholders. And the last one is all stakeholders, including the Ministry of Health Ethiopia, regional health bureaus, and the private sectors should cooperate to scale up the use of DATs in Ethiopia for better TB care. So once again, I thank you all of you for joining us today as we have delved into the critical topic of ensuring the sustainability of digital adherence technology. Thanks. Over to you.
Thank you, Tawfik. Yeah, really very thorough and in-depth understanding of some of the sustainability aspects that went into the implementation in Ethiopia. If anybody has any questions, we have about 5 minutes, maybe a bit longer, for questions. Okay. I'm just reading through the chat quickly. Please feel free to post any questions that you have so long. I do see one question here. The question is, do you have baseline assessment of TB cases before the implementation of the DATs and post-assessment to determine success of DATs in certain communities in Ethiopia?
Yes, before we went to the intervention, we conducted a baseline assessment. So based on that baseline assessment, we selected the health facilities which have more TB burden and other issues. Actually, I didn't went through all the project processes that we went. I just mentioned very few steps, those we follow during our implementation. But to answer the question, yes, we conducted the baseline assessment before the intervention.
Thanks, Tawfik. Then I see one person's hand is raised. Dr. Ahmed. Yeah, I see Dr. Ahmed posted a question in the chat, so I'll just read it out. The question is, did you address DRTB patients in the project in Ethiopia?
Yes, we addressed the DRTB patients in Ethiopia, but there were not that much. Very few DRTB patients were addressed in our implementation. Maybe in the future, we will consider more DRTB patients, and we will also consider health facilities who are working with the DRTB patients or who are taking care of the DRTB patients.
Thanks, Tawfik. Just one addition to that. In terms of DRTB patients in the last year with the WHO guidance on programmatic implementation for BPAL, we've also worked with the manufacturers of the smart pillbox to find a way to organize the BPAL regimen within the smart pillbox that Ethiopia implemented. And so you're able to fit approximately 4 weeks worth of medication, maybe longer, which I think is not preferable, but you could say up to about 4 weeks where a patient could take the BPAL regimen home and make use of the smart pillbox. And it's what we're providing guidance towards, that countries implementing BPAL at programmatic level should also have a very clear adherence strategy to avoid resistance, and the smart pill box we see as a very good solution in line with that as well. But that's maybe something that we could cover in a follow-up webinar, how you might implement digital adherence technologies for DRTB patients. I see one other comment in the chat, and maybe you'd like to say a bit more about it, Tofik. So it's not a question specifically, but the person says, I like the phrase private doctor at home. Are you able to elaborate a little bit on that experience with patients that you engaged with under the Ascent project?
Yeah, the patient who said the patient who had a pill box with him, he was really very happy having that pill box, because the pill box has reminders not only to take the medication daily, also the pill box also has a reminder to refill his medication once in 15 days. So this patient successfully completed his medication and he's cured. So finally, when we asked him his testimony at the end of his treatment, he says that having this a pill box with me is like having a private doctor at home. So it's like it's impressive. Yeah.
Thanks, Tofik. Dr. Ahmed, I see your hand is raised. Okay, Juan, are you able to enable Dr. Ahmed's mic?
Yes, mic and camera have been enabled already.
Okay, thank you very much. I'm Ahmed Bedru, a KNCB Ethiopia country representative. I just want to add on what Tofik said. Basically, during the project implementation period, he clearly mentioned those strategies we used to make sure that the technology is properly utilized and implemented. But I think he also mentioned at last that we had some challenge on the long-term sustainability, probably having this technology being a patient-centered approach. We have to really encourage and work together with other donors and national program to scale up the technology to be used for people in need in the country. I think that's part of the long-term sustainability. Needs a long-term work and very strong collaboration with the national programs, and also having more resource, because it is really it has a cost by itself. Each pill box has a cost. So countries sometimes, usually in developing countries, because of the limited budgets they have from global fund and others, they may not prioritize this technology to scale up. So probably we have to work hard on that area to make use of these technologies, really helping really patients, especially improving the patient care, patient-centered approach of the technology. Thank you very much. I just want to emphasize that part of it. Thank you.
Thank you, Dr. Ahmed. Then one last question is, how do you monitor adherence of TB patients using digital adherence technologies?
Yeah, yeah, thank you. We monitor we monitor the adherence is using the platform. There is a platform developed by a technology which integrates these digital technologies, the smart pill box, the medication label, and also the video treatment support. The VOT, actually, we didn't use VOT, but there is an integrator. We can say that an integrator which integrates these technologies, and based on that, the web-based and the mobile app has been developed. So the healthcare workers, they usually use the mobile app. So based on that mobile app, they monitor the adherence of the TB patients. So based on this, we monitor the adherence of the TB patients.
Thanks, Tawfiq.
Yeah.
Thank you. One other comment that I wanted to add to that is the webinar we hosted a month ago was related specifically to the adherence platform component. And we did record that webinar and posted it onto the website. Juan, maybe you're able to share the link into the chat so that anybody who would like to have more insight into the actual adherence platform component of Digital Adherence Technologies can have a look at that. But I would like to move on to the presentation by David Asimwe, and he is the National Coordinator for Digital Adherence Technologies in Uganda.
Okay. Thank you, and I welcome you all to this important webinar where we share experiences to ensure sustainability. I'm David Asimwe. I work with the National TB Program, Uganda, and I coordinate Digital Adherence Technologies at the program. So I'll give a brief about implementation of DATs in the country, our experience as Uganda, but also I'll go into details on how we've ensured sustaining what we've been able to achieve as far as DAT implementation is concerned. So the background, as we all know, TB adherence remains a big challenge, especially in the TB high-burden countries, like the country where I live, which present challenges like forgetting, lack of transport for patients to travel to clinics daily, but also presents with a lot of stigma and discrimination. And as a country, we saw that one of the potential things we can climb at was DATs, introducing DATs to try and solve some of these problems that we've encountered for so long. In Uganda, from 2021, we've been rolling out different DATs. One of them is the video supported treatment, which has been running from 2021 for 3 years now across the country, especially in the high burden facilities where we started from. And we've seen over 2,000 patients enrolled on 2VST with adherence rates of 94% registered. Previously, our treatment success rates used to be in 70s, 80s, but with the introduction of some of the parameters like DATs, we're able to achieve 94% in those patients that have been registered on DATs compared to the other group. We have reported a good adherence, but we've also tried out 99 dots, which ran in 18 facilities in 2019, and 2020 more 12 facilities were brought on board. Enrollment is still ongoing for 99 dots. However, it was presented with limited funding, and enrollment is a little bit low because of the funding issues around the 99 dots. But we're looking around to see that we get funds and scale up it to more facilities. And as a country, because we've learned a lot, quite a lot for some time, and with the technical support we've got from that task force, we sat and introduced smart pill boxes. Global Fund has supported us with the procurement of over 3,000 smart pill boxes, and procurement is ongoing, and we hope by July we'll have over 3,000 smart pill boxes in the country to scale up more DATs, but also to more facilities. One of the things we ensured was emphasizing trainings, but also supervision. By doing this, we developed and standardized the training materials so that we ensure capacity building for the healthcare providers. But also we made sure that we train key stakeholders, not the health workers, but we ensure that key stakeholders in providing the health services are also oriented and trained on DATs. We do this both physical and virtual. Where we can't reach easily, at least we plan virtual trainings and the teams are brought on board to start enrolling patients on DATs. And during these trainings, ensure that we explore explaining the potential benefits of DATs, both to the healthcare providers, but also to the implementing partners that are supporting various facilities. After training and rolling out of DATs, we ensure we do what we call targeted mentorships. And these global funders have been supporting this initiative of doing mentorships because by doing mentorships, we are able to enhance providers' knowledge on DAT, especially when this is carried out by. And also, it helps ensure that health providers conform to the evolving technological advancements. We found out that a number of updates keep coming on as we roll out. From the experiences we learn, we go into the technology, add something. So mentorships are good because there we are also able to provide retrainings, but also train health workers that were not trained before. So we maximize on mentorships to make sure that all health workers are on board to provide a service. But also developing a clear intervention management framework. In Uganda, we incorporated the DATs into the National Strategic Plan 3 years back, and this helped us to inform the health providers that this is part of the national plan to enhance adherence and treatment success rates. And also we included DATs in the NTP training manuals for health workers to buy in easily, but also the implementing partners. And we've embarked on developing guidelines. Global Fund is supporting us to develop guidelines for DATs. And this, I'm sure, will create a clear roadmap and inform policy makers on the implementation of DATs. But also we advocate for TATs so that we're able to share experiences and support the different interventions. For example, in 2022, we got a TA by the DAT task force in Uganda, in Kampala, and we were able to share our experience. They were able to share their experience, but also brought different people on board to read and understand what is concerned in the management of TB treatment. Yeah, we continue to advocate that DATs scale up require various stakeholders' engagement if we to see success and expanding of DATs, but also national TB program should steer all the processes involving implementation. At the beginning, DATs used to be research, and these used to be small scales. But when the national TB program came in and adapted the process, we can see the results that Uganda is expanding as far as implementing DATs. But also what we did also was to ensure that implementing partners were coordinated to understand the contents of DATs. And on this, we have a success story. One of our implementing partners is supporting the National TB program with mentorships, but also data for patients and airtime for health workers who continue coordinating the processes. And this came up as a result of coordinating the IPs. But also the regional IPs are also coming on board to support interventions in their regions. Funding for DAT is critical. We should all ensure that DAT interventions are included in all funding opportunities within the various countries. And that's what we're maximizing at as Uganda, to see that DAT interventions are being supported by the different implementing partners. As they budget, as they plan, we encourage them to include DATs in their regions. But also as a country, we consider scaling up different DATs to support all patient groups, because we learned that we needed to use different approaches. VST was good, yes, but it couldn't work in some patient groups. Some patients don't have mobile devices, mobile phones. Patients cannot afford the data, however much the programs for some smartphones to lend out to patients, but this cannot be enough. That's why we thought, yeah, let's bring in other DATs to support the VST approach. And the smart pill boxes are coming in to support the other patient groups, which we feel can maximize the smart pill boxes. But also contextualizing the DAT system. We've developed a system that fits into the local context. We got support from Global Fund still to develop our own system, so that we own it on our own servers. And that is a process that is also going on. And we encourage countries to invest in the DAT platforms. We've also ensured that data exchange for DAT systems with already country data capture tools, for example, WS02. Last year, we were able to integrate 99 dots with one of our data capture tools, the electronic case-based surveillance system, so that we make this data useful, but also meaningful for use. Data security is key, especially if we to make different stakeholders buy in the use of DATs. Everyone is interested in knowing where is our data kept and how do we access this data, and who accesses the data. And that's why I can't leave stage before acknowledging the Ministry of Health, which has steered the process of implementing DATs, the TB program, Global Fund, which has been our main funder in all the processes, the local implementing partners that are coming on board also to support, and the Global Data Task Force, which has continuously given us the technical assistance as a country. I thank you, and back to.
Thank you, David, for your presentation and the experience in Uganda. Please post any questions that you have for David or the Ugandan implementation in the chat. I don't see any questions now, but while we wait for questions to be posed, there is still one remaining question from the presentation by Tofik. So Tofik, if you don't mind being available to answer this question, it's what is your planning what is your plan to scale up DATs in Ethiopia and particularly in the Oromia region?
Okay, thank you. From our perspective at KNCV Ethiopia, as an implementer of the Ascent project, we are keen to expand the project not only in Oromia but also in other regions. However, this matter is still under discussion with the government and the donor. Yeah.
Thanks, Tofik. So while we wait for questions, David, I'm going to ask you a question about as Uganda, you're planning to do a multi-technology implementation, specifically video-supported treatment and the smart pillbox for now. How do you, or what is your plan in terms of patient groups that are enrolled on video-supported treatment versus patient groups that are enrolled on the smart pillbox? Do you already have a plan as a country in terms of how you would split the two, or how you would decide which technology is most suitable for which patient group?
Okay. Yeah, as a country, MDR has been supported a lot. Patients who are getting transport to move to clinics every day, and maximizing on the resources that were being given to patients to support VST for all MDR patients. The program has already procured the smartphones that are going to be used by MDR patients, especially those that don't own smartphones. And we're going to use smart pillboxes mainly for DS patients also.
So if I understood you correctly, you said that for video-supported treatment, you would be providing that technology to people on drug-resistant TB medication, and then the smart pillbox more likely for drug-sensitive TB patients. Like I said at the beginning of the webinar, that our intention is really to stimulate that cross-country learning. I see a question here. Okay, so the question is, are there any confidentiality issues that need to be taken into consideration when implementing DATs? I think to start with, this question could be posed to both Ethiopia and Uganda. So to start with, Tofik, may I ask you to respond to that initially, and then I'll hand over to David to respond.
Okay, thank you, Enes. Regarding the confidentiality from our side, we keep the data of patients in a secure the platform, in a secure database. That will not be revealed to another party. Even the researchers couldn't see the data of the patients. Only they don't see the name and other related the information regarding the patients. The researchers only can see the codes and other things. So there could be some confidentiality things to be taken when we implement DATs, especially related to the record of patients.
Thanks, Tofik. And David, do you have any thoughts from your side on that?
Yes, I think when as we plan to roll out, ensure that confidentiality and privacy for patients is paramount, and this should start with the DAT platforms that we use. Let's plan to build platforms that ensure confidentiality for patients But also what we do in Uganda, we make patient consent to which DAT platforms they wish to use.
Yeah, I don't see any other questions, so I'm just going to go to the last slide. And if you have any other questions, feel free to post them. So just as a wrap up, in terms of the Global DAT Task Force, currently we are fully funded to provide technical assistance to countries for the planning, the implementation, and the scale up of DAT. So that also looks at developing budgets for DATs and the proposal development for the inclusion of DATs in funding applications. I know a lot of countries have submitted their Global Fund applications in the last year, but for those countries that are still submitting applications, you can reach out to us for support of that, and also for other proposal developments through other funders. Then additionally, we provide support in the DAT and software comparison and selection. So as you've noticed this morning, there are a number of different digital adherence technologies, and there are also a number of different software or adherence platform options. And so we provide support looking at the country context and looking at the different technologies, what suits the technology, what suits the population best. And then lastly, for those countries that are already implementing DATs, in this case, Uganda was already implementing video-supported treatment, and we provided technical assistance to assess their technology and make recommendations based on the implementation that was happening. I see that there is one other question. Okay, the question is Zambia eligible to receive support from our group? Yes, absolutely. Zambia is eligible. This next slide, you see the email address that you can reach out to us on, and that is secretariat@tbdigitaladherence.org. You could scan this QR code on the right-hand side, or just go directly to our website. You can also submit a request through the contact form on the website. So please feel free to reach out, and we would be more than willing to support.